This is the security and privacy requirements to support exchange of health information. And this is a great segue topic from the tools of trust topic that we just had in the ballroom this morning. So the community of health information technology professionals is on the precipice of demonstrating encouraging health information exchange results with rapid acceleration of health information technology policy, standards, systems, and networks. And the cycle time to practical application of these systems is also shrinking. Right? And the result of that, we hope, is to see greatly improved health care, and quality for everybody. And incorporated within this transformational era, which it is an increased emphasis on security and privacy. Trust is an omnipresent enabler, not just for HIT, but for the broader scope of our nation's digital infrastructure, as evidenced by the administration's appointment of a national CIO, CTO, and the national, or still pending, I guess, national security advisor. While the shift in attributing responsibility and accountability for national cybersecurity is evident, it remains unclear how this will, exactly how this will affect health information technology, and more directly, the impacts on security regulations, laws, standards, and policies, and procedures within which we all need to understand and comply. So we are honored today to have with us two representatives from policy organizations, federal policy organizations, Ms. Suzanne Lightman from the Office of Management and Budget, who has a focus on federal security, and Ms. Jody Daniel, who spoke very eloquently on these same topics yesterday, from the Office of the National Coordinator, who has HIT policy responsibilities, including security and privacy. We are also joined by Ms. Julie Bond, who is the Chief Information Officer and my boss at the Centers for Medicare and Medicaid Services. And she'll offer us firsthand insight on the operational end of the challenges and opportunities that she faces and that CMS faces in guiding the world's largest healthcare payer organization. So I ask that we keep the questions to the end, and hopefully there will be time at the very end after all the presentations to take questions, please. Oh, I'm sorry, I forgot. Okay, I have to remember to talk and push. So here, just really fast, some of the topics that we'll cover. And the organization of the panel is such that we will start out with the broadest view, the Office of Management and Budget view of security and privacy issues, and then we'll move progressively down to more focused areas through Office of the National Coordinator, which is also a national view, and then a federal agency's perspective on security and privacy and security assurance programs that we need. And then I will represent the FHA-sponsored Federal Security Strategy Work Group and what we're doing relative to security and the Connect Gateway. Okay, Suzanne?
Did they turn this? Oh, they just turned it on. Okay, everyone can hear me now, right? My name is Suzanne Lightman. I'm the lead IT policy analyst in the Office of the Federal CIO at OMB, and my responsibilities are cybersecurity and HIT. And I'm going to speak, as she just mentioned, more about the environment that the agencies find themselves in as they move forward into this whole world of electronic health records. Obviously, there are many parts of the U.S. government that are in the vanguard of HIT. I mean, DOD and VA are probably the big ones that everyone thinks of. They each have full EHR systems that they use, and they use them in a meaningful way by any definition. But they have mostly conducted these activities within the U.S. government and not with a broad swath of non-government partners, and that makes an enormous difference as they move forward. Given that the U.S. government is, without a doubt, the single most regulated industry in the entire world, I think it's important, and as one of the groups that shows a lot of those regulations, I can say that with absolute assertion. It's important to ask what are the statutory concerns, policy concerns, and the responsibilities and needs of agencies as they move forward. First of all, the U.S. government uses health data in two ways. One, it generates it. I'm using very rough numbers here, so no one go out and then quote me on this. But around 10 to 15 million people at any given time in the U.S., with American citizens, are receiving care from some entity in the U.S. government. This includes the anywhere from 1 to 2 million, up to 3 million, I think now, that are receiving care through DoD. There's anywhere up to 8 million veterans. There are the tribal nations that are receiving their care through HHS. And then there are a variety of other small programs throughout the federal government where people are receiving direct care. However, the federal government also receives enormous numbers of records for which they use for other purposes other than patient care, mostly having to do with paying somebody. This can either be paying the providers, or it can be paying the person themselves in the case of SSA's disability work. So we sit in the peculiar position of being both a user and a generator of medical health records, easily one of the largest in the world, if not the largest. So as these agencies are doing all this, what are their major concerns and responsibilities? Probably the largest one centers around the Federal Information Security Management Act, known as FISMA. It was part of the E-Government Act of 2002. And FISMA arose because the Congress was fairly irritated with the agencies and felt that they needed to move forward on security in a more aggressive way. Let's leave it at that. And it establishes a whole series of requirements around security for federal systems and, more importantly for this discussion, for federal information. It requires that those protections, whatever they are, be commensurate with risk. It also requires that, since the protections move with the data, so that contractors should have the same protections over federal data that the federal government feels is necessary when they have the data. That sounds very simple, doesn't it? But you have to understand is that the Act, which the FISMA itself only runs about, I think, about 20 pages, has behind it a great deal of OMB memos, which are not very big. We write very thin memos. And then a mountain of NIST guidance from the National Institute of Standards and Technology that covers every single aspect, well, almost every single aspect, because they have some more they're still issuing, of everything that could possibly be covered by FISMA. I will tell you, though, that there is one thing that is required of all agencies that is not in FISMA. And it's probably the single part of federal security you've heard the most about, and that is certification and accreditation. I assume that most of you, if you've dealt with the federal government, have heard these dreaded words echoing down the corridors, probably accompanied by some very creative language. Certification and accreditation doesn't appear anywhere in FISMA. I want to make this very clear. OMB made it up. We created it all by ourselves, and we put it in the circular A130. That hasn't been updated since the early part of the century. But that's where certification and accreditation comes from. So briefly, and I want to make that clear because when I tell people that they can do a certain thing, they're all like, well, how do you know that? And I'll say, because it's our requirement. And then they all get very nervous that we can change the requirements. Certification is basically the responsibility of the agency to do a full analysis of the technical specifications and policies surrounding a system to determine if the security protections are commensurate with the risk and are present and functioning. This then leads to a recommendation to an authorizing official who gives the accreditation, which is the granting of an authority to operate, allowing the system to actually process federal data and indicating that management accepts the residual risks of the system. It sounds so simple. But there are many things one must do to achieve a CNA. You have to do a risk assessment. There's a Federal Information Processing Standard put out by NIST By the way, FIPS agencies must do with no exception. Special pubs 800s are things that you either have to do to comply with the FIPS or just things that NIST thinks it's a good idea that you do. So there's a risk assessment. The risk assessment requirement has a FIPS behind it, and then of course there are, I think, 2 now special publications on how to do the risk assessments. You have to have a system security plan. I think there's at least, last time I looked, I think there were 2, but there might be 3 special publications associated with how to do that. You have to test all your controls and key controls. There's a very, very large FIPS, 853A associated with that. Please never, ever, ever print it out. Ever. You have to do a contingency plan. You guessed it. There is a large special pub associated with that. And then you have to test your contingency plan, and there are actually, I think, 2 special publications associated with that. So you can sort of understand why the agencies think this is an enormous amount of work. I will say in defense of the CNA process that it arose because agencies would simply build systems and then put them into production and then go, we never considered the fact that somebody could steal data out of this system. And CNA was an attempt to move them forward, and many of the elements of CNA are actually individually required by FISMA. So agencies have to consider that entire FISMA CNA thing. But there's other things agencies have to consider because that wouldn't be enough. While some of these are many of the same policies that most of you have to, HIPAA and the requirements of the new HIT Act, others are unique to the U.S. government. There's the Paperwork Reduction Act. You wouldn't think that would have a lot to do with HIT, would you? But the Paperwork Reduction Act requires that agencies justify every time they want to collect data from anyone, any citizen, or actually anybody, to do their systems. So every time they start a health record system, or a system that's going to gather health records, they have to justify it. There's the Records Act. That requires that they actually record everything somewhere so at some point in the future historians can actually look at it. The Privacy Act, which requires that they protect the system and the information in the system so that your information doesn't get spilled out across the internet. But all of this wasn't enough. And in 2006, one of the agencies, who shall remain nameless, sort of allowed their data to kind of spill out. So OMB put some new requirements in. They're contained in Memo 0616 and 0716, and they require things like breach policies, notifications, et cetera, et cetera. These are very, very strict. For instance, you must notify U.S. CERT within 1 hour of determining that there was a breach of privacy information. It's 24 hours if somebody's dead, you know. You have 24 hours to notify us if somebody gets killed, but you only have 1 hour if you've lost your BlackBerry. And of course, when I talk about these acts, I'm using ACT as a shorthand for the sets of laws and regulations that back them up, because all of these laws have a lot of regulations behind them. There's all the regulations around the system of record notices, which you have to put in for the PRA and the Privacy Act, saying we're collecting this data, this is why we're collecting the data, this is why we feel it's justified, and then wait for everybody to tell you if it is or not. And the privacy impact assessments, which say this is all the information collecting, this is why we're collecting it, this is what we're doing to protect it, this is how we promise to destroy it, and this is how long we're going to keep it, and then wait for everybody to tell you if you're right or not. So it's a lot of work and it's very complicated. But all of these things exist because you're the citizens of the United States, want to be sure that the very, very powerful U.S. government is behaving in a responsible way. And the way that you express that is by passing laws. So I'm not saying any of these laws are bad. I want you to know that. I'm just trying to explain to you why it can sometimes be so difficult to deal with the federal agencies when you go forward in electronic health records, because they have a lot of concerns you don't have. I've been asked repeatedly about the role of FISMA with regard to HIT. You know, well, what if we do this? What if we do this? What if we do this? This is always by agencies, by the way. And I've always said, you know, the problem is that FISMA doesn't have any exceptions in it. It says that an agency head is responsible for the information and the system. And it doesn't say that you're only responsible until X happens or you're only responsible if Y happens. No, it says that you have an obligation to make sure that that information is protected wherever it goes and whatever it's done, as long as you believe that information needs to be protected. And agencies aren't absolved from any statutory requirements when dealing with HIT. So currently, agencies who are sharing or exchanging data have mostly been doing it either with partners who are within the federal government, DOD and VA. They both rate theirs at the same FIPS 199 risk level, and then they look at each other's CNA packages so they know that they're all kind of on the same level, and then they argue about it, and then it goes back and forth. But they get to they're on level playing field. Or they're exchanging with partners who they have a contractual relationship with, and under the federal acquisitions regulations, those contractors must obey the requirements of FSMA. That would be like when SSA is exchanging records with an insurance company. But what happens when all the records are exchanged electronically? What do the agencies do when they are asked by patients to send electronic records to personal health care record places? What's their responsibility then? What's the responsibility when people are carrying those records around with them? At what point is it no longer their responsibility? I don't have answers, by the way, so if you're looking for answers, you're not going to get them. But I think those are the questions that agencies have to ask themselves and come to answers on going forward in HIT.
Thank you, Suzanne, for your insights into OMB's positions on security and privacy and the overview of the CNA that's not in the FSMA. But it's something we'll touch on in just a minute. So next, we'll invite Jody Daniel from the Office of the National Coordinator to talk to us about privacy and security framework, some breach notification and incident handling information, and some Recovery Act implications.
Thank you. Thank you very much. Good afternoon. I had promised when I was up here earlier yesterday when we were doing our ONC presentation that I'd be back and I would be going into a little more detail about privacy and security and the activities that we are undertaking, some of the legal issues, and some of the projects that we see coming up in the future. I'm going to kind of take actually a step, I think, up a level, because what we're looking at ONC is how we make sure that information is protected, that there are appropriate protections in place, regardless of who's involved in the exchange. So we are trying to kind of look at very different levels. We are looking at the legal structure that we have in place, and I'll talk a little bit about the ARA provisions. We're also looking at some of the policies that may be broader that we would want to apply not just to the federal folks, not just to folks that might be covered by the HIPAA rules, but to anybody engaged in health information exchange. And then we're also looking at some specific implementation. How can we take some of the privacy and security policies or practices that we see as important and put them into practice either through NHIN, through electronic health records technology, and the like. So I'm going to try to cover all those levels, and I'll try to do it quickly. So let's see how it goes. So I feel as though in order to talk about privacy and security, you have to talk about it in the context of the value of health information technology. Clearly, the whole purpose of health information technology and health information exchange is to try to assure higher quality care by having information available at the time and place of care to improve the treatment of patients. So in doing that, if we need to be able to obtain the trust of all of the people involved in that exchange, the providers who are responsible for protecting their patients' information, the patients whose information is available to different providers, as well as others in the system. So if we don't obtain the trust of the providers and patients that are involved in health information exchange and whose information is involved, then we're going to have folks who are trying to take privacy protective measures and either prevent information from flowing, not share information with providers that are important, and that can have severe health consequences. So we're trying to figure out how to make information accessible to improve the quality of care, and how to put in the right protections so that folks trust and allow that information to flow. And it's a really difficult balance. It's something we've been struggling with for some time. We've made some progress on, and we still have some progress to go. So what's new in health IT, and how does that affect the privacy and security discussions? Hopefully, there's a gnat here. I'm not as good as the president. I don't know that I'm going to catch it. But so if you see me batting around. The hope is that health IT and health information exchange will give individuals the ability to have a greater role in their care, to have more access to the information, to be able to be engaged more in both their the healthcare services that they receive, as well as in managing their own health between healthcare visits. So that's an issue that we need to think about. There are new entities involved. When HIPAA was written, there was no such thing as a health information exchange organization. Well, maybe there was, but they were very few. It wasn't something that was considered. PHR vendors didn't exist back then. So there's some new entities that are on the scene. There'll probably be new entities that come about as health information technology takes off, and we need to think about how those entities play a role and how we can protect the information held by those entities. And I see the technology as providing new both challenges but also opportunities for protecting information. The technology can be leveraged to better secure information, to have better audit trails, to limit access to information to only those who are authorized, to be able to track if there is inappropriate access. So trying to figure out how we can harness the capabilities of the technology to improve privacy and security protections over what was available in a paper system. And then new questions and concerns come up. As you know, if information can all of a sudden be queried, does that raise new privacy concerns? There's lots of different issues that come about as information is flowing differently, and so we're thinking about how those play in. Oh, there's new. Somebody played with my slides and made them much prettier than I had before. This is great. I have elves, I think, somewhere that are graphics elves. So, like I said, I'm going to talk about this from three levels. From a policy perspective, sort of a broad overarching policy perspective, which kind of goes above the legal structure that we have in place. Talk about the legal obligations that are out there with respect to privacy and security and what's new, and then talk about some specific implementation, and particularly privacy and security with the Nationwide Health Information Network. So the Nationwide Privacy and Security Framework, this is a document that we put out in December of 2008. The goal here was to have to come up with a set of high-level principles for privacy and security that were focused on health information exchange and are based on fair information practices. So the principles that are set forth in the privacy and security framework are not, anybody who's been involved in this field will not see anything in there that is shocking or new or completely out of left field. It's based on existing principles for fair information sharing practices, but we tried to tailor it to health information exchange and to the new environment that we're in. What we have is a set of principles that are designed to apply to all persons and entities involved in electronic health information exchange. So this would be, you know, if there's a PHR vendor that is involved in health information exchange, we would expect that they would follow the same principles as the physician who's involved in health information exchange. So it's to try to set a level playing field for what the expectations are for fair data sharing practices. What we're expecting to do with the privacy and security framework is build on it. So those principles should stay stable. That's why they're high-level principles. But our next step and what we hope to do is to develop some implementation-level guidance, to develop some specific policies that might apply to health information exchange as we encourage adoption and promotion of health information exchanges across the country through our state grants. So we're going to take that as the foundation and build on it, build some policies, build implementation guides, and build tools to help folks. What we expect is that these would be guiding principles as somebody is setting up a health information exchange, as they're working with providers to get them engaged in the exchange efforts, that these would be the principles for those activities. At the same time that we put out the privacy and security framework, we put out some tools that, that were companion to those principles. I'm actually going to start from the bottom up. The first was we put out some guidance related to the privacy and security framework on HIPAA. We worked closely with our Office for Civil Rights. What we had heard was that there were lots of questions about how the HIPAA privacy and security rules applied in health information technology and health information exchange environment. So what we did, we have guidance that are tied to each of the principles, explaining how, as a HIPAA-covered entity, you can meet the expectations of these principles consistent with the HIPAA rules. And we've clarified some of the HIPAA rules and how they would apply in health information exchange and health information technology environments. From a security standpoint, one of the principles is about safeguarding information. And what we found to be an area where there needed to be a little bit more emphasis is working with small providers and helping them to understand how to think about security. So we came up with a guidance document called Reassessing Your Security Practices in a Health IT Environment. It's a guide for small practices. It helps walk a small healthcare provider who doesn't have a security expertise or background through the kinds of issues and questions they should be thinking about as they adopt an electronic health record or as they adopt an e-prescribing system, as they start exchanging information. What are the new risks they should be thinking about? What are the new technologies they should be thinking about? How should they be thinking about protecting that data as they change their practices, as they become more electronic, as they begin to exchange data more regularly through electronic means? So that was the purpose of that. And then the third tool that we've been working on is a draft model privacy notice for personal health records. So currently, the HIPAA privacy and security rules, the federal rules on privacy and security that apply to private sector entities, don't necessarily apply to PHRs. It depends. There might be some that are tethered to a physician's EHR, and if the physician is managing that PHR, it might be covered as part of their requirements to follow HIPAA. But Google Health or Microsoft Health Vault or No More Clipboard or any of the other PHR vendors that are out there that offer a standalone PHR that they market to consumers are not necessarily covered by those rules. So we talked to some of the PHR vendors, and we're trying to figure out how do we encourage consumers to get access to their information, to get more engaged in their care, but to make sure that we're not encouraging that without folks considering the privacy risks, since we don't have necessarily the authority to enforce against privacy or security violations in those products. So what we started doing was trying to figure out how we can make that information transparent, how we can encourage PHR vendors to communicate their privacy and security practices to consumers so that consumers are able to make informed choices about using those products. And thereby, we're also hoping that as we encourage them to be more transparent, that they would want to be transparent about and think carefully about what their practices are and not necessarily have to say in black and white, we're selling your data. And that perhaps they would come up with more privacy protective and security protective measures. Where we are in that process, we put out a draft notice, and we are currently trying to revise that, and we're going to be doing a whole set of consumer testing on the model privacy and security notice. We're actually waiting for OMB clearance under the Paperwork Reduction Act before we can do the consumer testing, so we're a little bit on hold right now because we're following our legal obligations. We'll talk later. Yes, we'll talk later. So our goal is to have, I think our target now is spring of 2010, to have a template, a notice that PHR vendors could use that's consistent so that consumers can actually compare. They can understand how the PHR vendor would use or disclose their information, what security measures they have in place, and we're working very closely with the Federal Trade Commission, who has in the past and we've been talking to you about their ability to enforce if somebody does something in violation of their stated privacy notice. So that's what we're doing there. Which leads me to ARA. Under ARA, the HITECH Act set forth, as we had all talked about yesterday in our ONC conversation, a whole set of activities that we are required to do. But in doing that, to try to promote health information technology and health information exchange, but in doing that, they also added some privacy protections for concern that this new environment may raise new issues that they wanted to address. I mentioned this yesterday. We have 2 federal advisory committees that were established under the Act, and the only reason I reiterate that today is that we expect that both the Policy Committee and the Standards Committee will be giving us recommendations on privacy and security issues. The Policy Committee from a policy standpoint and the Standards Committee from a standards and technology standpoint to help us understand what we should be putting into electronic health record certification requirements so that systems have capabilities to protect information. So what changed under ARA for the HIPAA rules? We had, I categorized these in 4 areas. One is modifications to the existing rule. I want to stress that what ARA did was basically build on the existing framework, the HIPAA framework, and put some Band-Aids, expanded some things to more people, added some provisions, but basically kept the same conceptual framework for privacy and security protections. One of the biggest things, I'm just highlighting a couple of big things that were changed. One is applying specific provisions to business associates and allowing enforcement directly against business associates. So this was big. It's trying to increase the bubble of protection. The second is a breach notification requirement. This is now a new federal requirement for entities to notify individuals in the case of a breach, unless the information is rendered unreadable, unusable, or indecipherable. And we've recently put out guidance on what that means and have received comment on that and are processing those as we speak. And then finally, there are some specific changes. So talking about electronic access to information, accounting for more types of disclosures, et cetera. It also put in a breach notification for those PHRs that I mentioned were not covered by HIPAA. Well, now they are covered by the breach notification requirements. So that's a new additional requirement, a new type of entity. They enhance the enforcement activities by increasing penalties, encouraging OCR to impose penalties more often, and most importantly, or most interestingly, I think, is that they've now allowed state attorneys general to enforce the HIPAA privacy and security rules, which I think the thinking was that that would lead to more enforcement. We're going to be working very closely with state attorneys general to make sure they understand the privacy and security rules so that there isn't inconsistent enforcement nationwide, which is a concern we have. And then there is requirement for educational efforts so that OCR has to educate folks about the HIPAA privacy and security rules and come up with an education campaign. So privacy and security in operation. And I'm not going to talk in too much detail about this, and I touched on some of these yesterday. So we have been working very closely, or my shop, the policy shop, has been working very closely with the folks doing NHIN to make sure that the policies and the technologies are aligned. And this is a challenging task because oftentimes the policy you can't identify the right policy unless you have the technological capabilities to implement the policy, but you can't develop the technological abilities until they know what the policies are. So we're trying to work hand in hand. The bottom piece on NHIN is this privacy and security. We actually have a privacy and security work group that we have formed to bring the policy and the technical folks together so that we're identifying what are the best approaches from a technical perspective that meet the best policy objectives, and we're trying to balance those and work those together. Going up the chain, we are also working specifically on one of the use cases, the consumer preferences use case, because this is so wrapped up into consent issues and authorization issues and the state laws in these areas, and we're trying to make sure that the technical capabilities are there so that we can set better policies on privacy and security and consumer preferences and make those more easy for folks to implement from a technical perspective. And then we've been working very closely with the folks who have been setting up the Data Use and Reciprocal Support Agreement, which is really the legal foundation for the NHIN. It's trying to establish some of the baseline legal policies for all of the participants of the NHIN to sign on to so that everybody's following the same rules of the road. And there's some privacy and security issues in there, and actually had a whole lot of discussion. Probably the most challenging conversation was about FSMA and how do we deal with security in the DRSA, and that one is still an open-ended issue, and we will be talking with Suzanne in the future on that issue as well. So we work very closely with our OMB colleagues. So we're trying to make sure that as we're implementing policies, we're looking at how the framework fits in with some of the NHIN specifications and making sure that the NHIN specifications are enabling folks to meet those principles. We're trying to marry these two together in our NHIN activities. The other thing, so that's on the exchange side, and we will also be looking at how we can implement the policies that we're setting forth in the privacy and security framework through ARA, et cetera, into our state grant activities so that as the states are developing health information exchange capabilities, those issues are incorporated. And then finally, we're trying to figure out how we implement privacy and security into EHRs by making sure that there are certification criteria to have the right security protections in place. So if in fact we want to make sure that there is an audit trail, that has to be built into the product. So we're looking at where there are opportunities for developing certification criteria or requiring certification criteria through our regulation that would then be required to be in a certified product. And there's a lot of leverage there now because if somebody wants to get an incentive payment from Medicare and Medicaid, they have to be using a certified product. So I think there's a lot of opportunity there to really up the protections and up the capabilities of the products through our authority to set certification criteria and standards. So all of this kind of fits together. We're looking, like I said, we're looking at privacy and security in different levels, from sort of the broad policy perspective, from the legal obligations perspective, and HIPAA, ARA, and then also from how do we bring that all down into the operational level and make it meaningful and make folks actually help folks actually implement the protections that need to be in place to get the trust that we need so that folks will make information available to better treat patients and improve quality of care. And with that, I turn it back to Ashley. Thank you.
Thanks very much for sharing. Okay, so next we'll hear from Julie Bond, the CIO and Director of the Office of Information Services at the Centers for Medicare and Medicaid Services. And she'll, I think, kind of bring back around the FSMA debate again and what concerns are at the operational level for us. Thanks.
Thanks, Ashley. So I stepped down off the stage, but I'm going to tell you right up front that I'm getting on a soapbox. So just imagine that I've gotten on a soapbox, but I can walk around. My staff will tell you I always like to walk around at meetings, and it's really so I can look them in the eyes. But I have a particular message that I want to bring to you all today. Since we're talking so much about health information exchanges and technology. And you heard Suzanne talk a lot about what federal agencies are subject to and have to do in order to meet our FSMA requirements. And one of those things is we have to continuously look at our systems and test them and make sure that things are going okay. And as CMS, we get a lot of help in doing that because we have our Inspector General who looks at a lot of things for us as well. So a couple weeks ago, as part of the Chief Financial Officer's audit, they were looking at some of our systems. And they found what is actually a pretty significant security vulnerability. And I'm going to leave it at that. And these are systems, this is systems that we've been covered by FSMA since 2002. Before that, it was GISRA. And before that, we were actually starting to look at systems. And this system's been around, by and large, since those days. And we did not know this. And thank goodness the auditor did that. And thank goodness the auditor was looking at this system because now we fixed it, right? Fortunately, when you find significant security vulnerabilities, they tend to be pretty easy to correct. And this one actually was. But it's probably been around for a while, and that's a disappointing thing to me as the Chief Information Officer. What I'll tell you is that when we look at ourselves from a security perspective on a continuous basis, and also when we've begun looking at, we've been venturing out into personal health records and we've been venturing out into some other areas in health information exchanges, and we've had to look at new and different partners from the ones that we've usually had to look at from a security perspective because, again, Suzanne and her colleagues require that we do this. I can tell you that we as an industry need to raise our game in information security. We are not doing a good job. And let me tell you another example, okay? We have colleagues at the Department of Homeland Security who are looking at malicious software, malicious things that are happening on the internet. And when they find things that have to do with our systems, they'll tell us about it. And one of the things that they're telling us about more and more these days is the incidence of key loggers, key logging systems being on user computers on the internet, right, who are then accessing our systems, and the Homeland Security people can tell us that some bad guy has seen, for example, user credentials accessing our systems over the internet. So what we've been doing with these people, and largely these are not our contractors, okay, people working on our behalf. What we've been doing is letting them know. We've, of course, immediately disabled their access and let them know that they have a compromised computer. In one case, the particular compromised computer was actually controlling medical devices, right? Which means it's FDA approved, right? Which means that it's unpatched, because if they patched it, the FDA approval doesn't apply anymore, all right? Might I suggest that compensating control might be that this computer should not be connected to the internet? Because now what we have is a known compromised computer that can't be corrected that's doing medical things. Does that scare anybody? You want that computer on your care at all? Scares the you-know-what out of me. And this is not a computer that I actually have any sort of authority of or responsibility for under FISMA. But it's all just an example of we as an industry must raise our game. Okay? Now, so I talked about that. So let's talk about what some things that have been going on in information security. Here's a phrase I hope we stop using really quickly. FISMA Light. What the heck is that? Or HIPAA Plus, right? As if there's some middle ground. And Suzanne has not paid me to say anything that I'm about to say. Okay? Let me ask you a question. I'm going to start with this question. Shouldn't we all use FISMA as a guide, at least, in how we implement information security? Is FISMA asking us to do anything that's terribly unreasonable in information security?
You are using we as in not federal government.
I am not saying this in terms of just agencies, okay? I absolutely am not saying this just in terms of agencies. To me, FISMA is a set of guidance that, in some cases, I will say, I don't get to make decisions. We all make risk-based decisions every day. Raise your hand if you have a deadbolt door on your deadbolt lock on your front door. Raise your hand. Hands up if you have a deadbolt on your front door, okay? Keep your hand up if you also have a security alarm system. Okay, a whole bunch of hands went down, right? We all have different tolerances for risks, and we manage the risks and we make decisions every day. Probably most of you have homeowners insurance, I would imagine, if you own a home, right? And you have auto insurance, but you probably have different deductibles, right? We all make these decisions every day. As a federal agency, I have some lenient, as a CIO of a federal agency, I have some leniency in the decisions that I make, but other places, OMB and NIST, tell me I don't have any. So I can't decide it's okay not to encrypt my laptops and mobile media. They tell me I have to do all of it, it's all done, right? And we check to make sure it's all done. What FISMA asks us to do, certification and accreditation, that's one of the things, but I'll talk a little bit more about what that means. Document our security plans. What do we do for security, right? How are we making sure that these things are secure? And to continuously monitor ourselves. Imagine if I took this certified and accredited system that I told you about at the beginning, said, whew, thank goodness that's done, I'll go look at it again in 3 years, right? And hadn't been looking at it, I would have not known this issue. All three of those things have to be done commensurate with the risk of the system. Let's talk about risk. So what are we protecting at CMS? Obviously at CMS, we run these little health insurance programs called Medicare and Medicaid. You've surely heard of these. So we're protecting a lot of money. Over the course of a day, our programs pay $1.2 billion every single day, right? That's kind of a lot of money. It's a lot of your money. I have a line on my pay stub that says Medicare, right? It's a lot of your money, and of course there's that federal tax line. I like to make sure that we're accounting for it properly. We have protected health information for more than 90 million alive people and another about that same number of dead people, believe it or not, because Medicare beneficiaries have a tendency to die, but we keep their data. But almost more importantly than the protected health information and the confidentiality is the care decisions that happen as a result every single day of the data in our systems. We are a very large health insurance company. When you go to the doctor, one of the first things they'll ask you before you even see the doctor is your health insurance information the same? And do you know why they asked you that? Because before you get in to see the doctor, they're going to submit a query to your health insurance company. Are you going to pay me if I see this person today, right? Or if I do what I think I need to do to this person, are you going to pay me? So we are a health insurance company. We have that same capability, right? An eligibility inquiry and response, it's called. So if that data in our system doesn't have integrity, and it doesn't give the right answer back to the provider who's trying to make a care decision on the spot for a Medicare beneficiary, then the decision about whether to provide care or not could be incorrect, right? That's important to all of us, isn't it? Think about, your own care, right? When you're in any sort of medical provider environment, and you want that care to be right, and they're relying on data and systems to do that. So we have a lot of important stuff to protect. And CMS, probably the major difference between CMS and other players in the health industry is we're really big, right? We have a lot. But everybody has the same sort of level of risk. Is this important stuff to protect? Is this important stuff to protect? I'm sort of seeing head nodding, so hopefully I've got you agreeing with me here. So one of my colleagues mentioned this. I think it was Suzanne. Our friends from OMB are always so helpful. In 2006, there was kind of a well-publicized information security incident, right? Never gonna bend down. This has colored my thinking, obviously, for the last 3 years. Okay. Imagine what would happen from our friends in Congress and the administration, from OMB, from others in the industry, were there to be a similarly well-publicized security incident involving health information data or a health information exchange. You think it's bad now? Right? We'll get told what to do really, really quickly, right? And what I really worry about in that regard is that we as an industry clearly have a mandate from this administration, right, and even the previous administration, to take technology into healthcare. That's why we are all here, right, today. To take technology into healthcare and to make it real, right? Make it meaningful. Make it actually help. If I have time, I'll tell you my grandmother's story in a second, but I'm not sure I'm going to have time. If we set that mandate back because we allow an information security breach just on the publicity side of the one that happened in 2006 to happen, we will be doing the country a major disservice, right? That is our mandate. So let me go back to FSMA, okay? So I want to scrutinize it just a little bit more closely. So I brought show and tell stuff. Ooh, show and tell. Suzanne will know this one. This is last year's OMB memo to CIOs about what we had to do in our annual report. Okay? This is the kind of stuff that scares people about FSMA. They say, oh my God, it's too expensive, I can't possibly do it, and I have to have FSMA Lite, right? So, I'm going to read you some stuff from this memo, and you ask me if this seems unreasonable for those of us who are protecting the stuff that we have to protect. The head of each agency shall be responsible, and imagine if that was healthcare provider, healthcare entity, shall be responsible for providing information security protections commensurate with the risk and magnitude of the harm resulting from unauthorized access, use, disclosure, disruption, modification, or destruction. Does that seem like an unreasonable thing for a system that has your data in it? That I actually have to care about protecting it? So let's go back into the what's in the actual report. I actually highly encourage you to read this, right? In the actual report, I have to answer questions about my systems inventory. Is it unreasonable to expect the healthcare institute to know what their systems inventory is? I don't think so. CNA, let's talk about CNA a little bit, certification and accreditation. Oh my God, that's so hard to do, I can't possibly do it. All it really says is that I looked at my system from a security perspective. Are the security requirements that I documented at the beginning actually implemented and working? That doesn't seem like a hard thing to do, or even an unreasonable thing to do when you think about what we have to protect, right? So take a look at this OMB memo. It's actually not that frightening, right? Then the thing that really scares people. Yes, I've brought it. You can run screaming from the room. This is NIST Special Publication 800-53. It happens to be the final public draft that just came out this month of a new update to it. Huh? No, it's not the thickest one. This is the one that has the famous 170 information security controls, right, that make FISMA impossible for anybody besides big, huge federal agencies with massive budgets to implement. But I'll go back to commensurate with risk, right? So let me look at a couple of these, and I'll ask you if you like this. And I just sort of randomly opened this up. I didn't actually pick ones that seem perfectly reasonable, but here's one. This is actually a control enhancement, believe it or not. The organization analyzes new software in a separate test environment before installation in an operational environment, looking for security impacts. Is that hard? Is that something you want happening with the things that protect your health information? I do, right? Then another one, configuration management, it was one of my favorite topics. That's why I picked that one, because it's an area that at CMS we have a lot of room to improve. So this one is another one in the category called denial of service protection. Okay? Again, this is a control enhancement, believe it or not. The information system restricts the ability of users to launch denial of service attacks against other information system or networks. Don't you want your systems to do that? Some of these actually are harder. Okay, I admit that. But shouldn't they all be looked at when we're talking about systems that do what these systems that we're trying to protect do, and when we're trying to move information around? So, it's your data. Raise your hand if you would like your data in a system that's protected by FISMA Lite. You're kidding. Oh wait, one person, really? Are you serious? FISMA Lite would be okay with you?
Well, actually, I would like to control my data from the patient's perspective so that I have the authority to make available my information to who I want to make it available to.
Good point. Except for once it goes to the healthcare provider, he wants to protect his own data and have control of it. Who doesn't? I can't turn this into an interactive thing because I'll run out of time and get lectured, but I do like interactive things usually. At any rate, but once you hand it over to somebody and it's in their system, right, and then they're trying to make decisions for your care, you want them protecting it, I think, commensurate with how you think it should be protected. This is not that frightening of a document, and it's probably one that should be looked at by organizations who have the things to protect that we're talking about protecting. And again, commensurate with risk. It's always commensurate with risk. See, I have to wrap it up. You're not going to be able to hear my grandmother's story. Sorry about that. I don't. How much time do you need?
So please tell the story.
All right. So my grandmother is 92 years old, and she's a Medicare beneficiary. And I, through some major family drama, have like primary responsibility for making sure she's okay. And 2 weeks ago on Sunday, she fractured her hip. And that Monday following that, she had partial hip replacement surgery, which went great, and then she got released to a rehab hospital in Baltimore on the Thursday following that, and been doing fantastic. Matter of fact, I've been making plans to move her back to her apartment. Yesterday, she has a little bit of a setback. She has some bleeding happening in the surgical spot. And so they, at the rehab hospital, can't deal with this. So they send her to, they call an ambulance and send her to a local acute care hospital, which is not the hospital where she had her surgery. So I meet her over there, right? This is a different hospital in Baltimore. This hospital, what they sent from the rehab hospital was papers in an envelope that for some reason the people at the new hospital weren't reading because it had all the information, and they kept saying to me, well, what brings you here today? How did you get here? And this is a reputable hospital, don't get me wrong, okay? And at the rehab hospital, they'd x-rayed her hip, but do you know what they did at the new hospital? X-rayed her hip again. And she's stable, and hopefully the new hospital doesn't want to deal with her. They want the doctors who did the original surgery to deal with her. But it was actually kind of frustrating from my perspective to be answering these questions again, to make sure that they knew why she was there, when she'd had her surgery, which was only 2 weeks ago, right? What medications she was taking, you know, had she taken them that day? What was the result of the x-ray? We need to make this stuff happen, right? We need to make this stuff happen. And if we screw up the security and privacy, it won't happen, okay? Soapbox. I promised you I was going to be on a soapbox. See, I'm a little hot about this because I was at the hospital till after midnight last night, so I'm ranting a bit. So FSMA requires that we implement a risk-based information security program. My assertion to all of you is that this is not too much to ask of us as an industry. And I told Suzanne did not pay me. I'm not here to do this. We are being asked to do this because it's what the country needs in order to move healthcare, to advance healthcare forward, right? We need this technology stuff. So, again, I'll ask you, is FSMA Lite okay for your data, right? And if it's not okay for your data, we shouldn't accept it for everybody else's data. And I need you all to join me in raising the information security bar. Ashley?
Thank you, Julie. Now, in stark contrast to Julie's peripatetic presentation, I will give the camera guys a break in the back, and I will stand here holding on for dear life to the podium. So I'm going to take this down a notch, and what we're going to be talking about, what the Federal Security Strategy Work Group has been discussing and building a plan for securing, and then an actual, and we're actually certifying and accrediting the Connect reference architecture gateway software. So I'll talk a little bit about that. Very little, actually, about that. So as co-chair, along with Dan Galick, is the Health and Human Services Chief Information Security Officer, who is my co-chair of the work group, was convened of federal partners initially to work through what are the barriers, are there barriers, and what are those barriers to more widespread exchange of health information, and how do we bridge that gap? And we talked a lot about that in the DRSA meeting, because all of these things are, you know, sort of orbiting together to make this happen. So the Federal Security Strategy Work Group falls under the purview of the Federal Health Architecture Group within the Office of the National Coordinator. It was convened on September 30th, 2008, at the urgings of Julie Bond and other representatives from CMS to, and she said this, if we can't secure and safeguard the data we're going to share, then we can't share this data, we can't do it. So the group was convened immediately, 5 days after the discussion, to start focusing on how to make that happen. And when you get a room full of security professionals and privacy professionals, not a lot happens, actually. There's a lot of talk. Sorry. There's a lot of discussion. And actually, I'm totally joking. A lot did happen. But there is a lot of talk, and there is a lot of paper about what this means. How do we get there from here? And so I think we're probably in a place now where we need to escalate the conversation to the agency heads, and I think that is our next plan, is to have the agency heads come together of CMS, VA, DoD, IHS, SSA, NIH, CDC. I think that they're the heavy hitters in the healthcare realm, and to meet with OMB specifically, and to talk about how do we make this a practical thing, not just to talk about securing the data, but how do we make it practical? How do we afford doing the security testing and evaluations? How do we afford having regular cycles of the continuous monitoring of that information? How do we
Ashley, you only talk to us when you want money.
We're going to start talking to ONC for money this round, I think. To do that. But actually, this is a perfect example of how we move this out of the federal purview and really make this a public-private collaborative, and that we all pay into this together because we want the same things out of it, right? So. So we're not really talking about money, but there is an impression that it is expensive to be in compliance with FSMA. I was going to say something else, and that you need a staff of people to monitor and control the many documents that you develop and track over the life cycle of your various systems that do this. So, but. We'll talk about this in a minute, but we'll see that we can work this out together and kind of chunk up the pieces of it. Right now, the feds pay for all of it, actually, for those contractors and entities who are doing work on behalf of us. We cover all of that now. But that's not a really good way to go forward. And as we broaden the scope of the exchanges, and with non-traditional partners, people with whom the federal agencies are not directly contracting for specific business activities, then that's not very feasible to do that. So those are some of the things that really need to be worked out, and that's what the Federal Security Strategy Work Group is doing kind of behind the scenes. So one of the things, I just have a little statistic that may be interesting to some of you. About roughly 60% of the HIPAA security rules map directly to the FSMA controls, the security controls. And so that kind of means there's some big gaps and there's some small gaps there. But that kind of means that only 60% of an organization that's only complying with HIPAA is also able to comply with FSMA. So, and that's for kind of moderate system, a sort of garden variety system, actually. But we are talking about that does contain PII or PHI information. So the Federal Security Strategy Work Group and other work groups, Jody mentioned, and there are several. There's actually a large number of groups who are very concerned about security and privacy, and they're working that from the NHIN perspective, from the larger framework perspective, and from a pragmatic, how do we make this happen perspective. Oops. So, I'm not really good about pressing, moving forward in the slide, sorry. Which is why it's always a good choice not to have slides, I guess. So the Federal Security Strategy Work Group has, in fact, drafted some interim guidance that's still under review. It hasn't been shared outside of the federal participation arena and it's really largely for the federal partners that focuses, as Julie more than mentioned, on a risk management-based adequate security assurance under FISMA. And in fact, this guidance is already built into FISMA 853 that says whoever the agency designated approving authority, it may be the CIO, it may be a chief information security officer, it may be another designee by the head of the agency, has the authority to apply a cost-effective risk management-based approach to allow health information exchanges between federal entities and non-federal entities if an assurance of adequate security can be manifested there. And the federal designated or approving authority should consult with other federal authorities if that exchange includes another federal partner, because you want to make sure that that all the federal partners involved can do the same kinds of things together. Even though we're subject to the same regulations and statutes, we don't always necessarily implement them the same way because we have different data needs and different business models. So there may be a difference there. And so the one situation that I'm really focusing on is where there's no coverage really, other than the individual organization's decision to cover and safeguard the data, is where an entity is not doing work on behalf of the government. Then what laws apply? And so that's the gap that we want to fix, right? Otherwise, FISMA applies for us. So the interim plan calls for special or additional agreements, like data use agreements or memoranda of understanding, to back up the rules of engagement, the rules of behavior in this exchange is very important. And overall, the object of this game is to determine the risk to the participating organizations' operations and their assets, and the acceptability of such risk. So this is a little glimpse, a very high-level glimpse into where the federal security strategy is going, looking at a whole information security service model to an approach to building a public-private collaborative for security or primary security. And the service model approach is comprised of the following components. There we would use security standards such as NIST, OMB, HITSP, et cetera, and the list is rather long, I think there, may determine. We would use certified products, software products, reference architectures, like the Connect tool. And there we have CCHIT is a factor, and then even in terms of certification, that Suzanne talked about, the certification and accreditation of the tool itself would fall under this category. And then there's an importance of verifying the exchange of information, and then also an aspect of that is a whole key piece of identity management, which we really haven't touched on too much in the seminar overall, yesterday or today, but that's a huge opportunity, I guess, and certainly a challenge for how we might actually manage disparate parties, knowing that who's requesting the data is really who it is, and has the authority to request that data. So site monitoring, because part of FISMA includes physical security aspects, and that you've implemented your systems and your software in a way that meets the needs of why you're using it. And then governance over all of that, which includes the whole enforcement factor. So if there is a naughty player in that exchange. How do we deal with that? So I move from the work we're doing and things we're thinking about to what we're actually doing for the Connect reference architecture software. So the first 3 bullets here, if you're at all, I mean, these may be very familiar with people who do work with the federal government. This is the sort of methodology to present, test, certify, and assert the security posture for a system using the selected controls for, depending on the purpose of that system and the type of data it has. And security assurance is arrived at on the basis of security assessment and risk acceptance, which is ultimately approved by that designated approving authority. So one of the things, important thing to, and why we're doing a full-scale certification and accreditation of the Connect product is because Connect is a very agile, can I say product? Is that okay? Okay. Agile and fluid in its evolution. You want to establish a baseline of its efficacy, of its security efficacy. And so as the target architecture changes over time, you're able to also monitor and show that your security parameters are also, and your whole security program is moving with those changes over time too. And one of the benefits of, or a key benefit of doing this is the development of common artifacts and documents and controls that Suzanne and Julie have spoken to, that everybody can share. You have a centralized product that is certified, and everyone who uses the gateway also shares in that certification, and that helps to inform your edge systems and your partnering systems for that too. So, see, it can be cost effective to just when we share. So one of the things that we have to do is identify security controls and reusing those common controls across the partners. That's all this is talking to. And I guess we're over time, aren't we? I didn't get my red card. But the important thing, I think we emphasize, in a minute, just let me close on one thing, is that this is not a one-time deal. This is part of you have to build it into your business model, your workflow, so this becomes a part of how you see your business and how you see your data assets and why you're doing that. And I think, Dave, do you want to say something about when some of this might happen? Sure. Okay. Do you want any of those?
Yeah, well, it doesn't matter on that slide. I'm Dave Riley, the Connect Initiative lead, and so security and privacy is obviously a concern in the NIND and something that we've been working very hard on at the specification level. In terms of Connect as a product, we obviously, in the fact that it's being built by federal agencies and federal agencies have to meet FISMA requirements, it's going to meet FISMA requirements, so there's no question about that. And so as a part of that, we're doing this certification and accreditation. It is currently underway, and we expect that the CNA package will be complete for the 2.1 release, which is occurring on July the 7th. We'll do an update to the package to reflect the changes that are coming out with the product then. And so we should see a completion of this by the end of September, which is in time for federal agencies that are planning to go into production limited pilots in the last quarter of this calendar year. We take the security and privacy concerns very seriously in the development of Connect. I use a number of tools to look at the software code itself. And so one of the enhancements that we'll be doing in the next release cycle as a part of our testing cycle, there have been identified approximately 700 security practices, if you will, or flaws that programmers commit on a regular basis when they're building software. And so there are some tools that we can now use as a part of our testing sequence to go look for those things on a regular basis. We've run the tool against the existing version of the software, and we have systematically knocked out as many of the things that we have found with respect to defects or flaws in terms of coding practices. And as we move forward, we intend to run this on a daily basis against the code baseline so that every time we do a nightly deployment of the software, we will be running this tool against it and generating reports so that we can identify as new programmers become involved with what we're doing. If they commit one of these security sins, and from a programming perspective, we'll discover it early and we'll eliminate it early. And so this, as Julie has pointed out, it requires continuous monitoring, and so we will be continuously monitoring the software throughout the development cycle so that we can raise the bar in terms of security for the whole industry. So as folks are adopting the use of Connect in their environments, there are additional things that they need to do organizationally. Connect by itself is not going to make you FSMA compliant. There are administrative and organizational, operational things that you need to put in place to be fully FSMA compliant. But the point is it gets you significantly along the way to where you would need to be if we raise the bar to the level that Julie's talking about. And I don't see any reason why we shouldn't be concerned about our privacy and protecting our data in that way. So this is a tool that we're trying to put out there to make available for folks to help get us to where we need to be so that we can securely protect the data and enhance privacy and confidentiality for patients. So.
Thank you. Thank you very much, Dave. And thank you, panelists, for your time and sharing information. I think it's lunchtime.